Well, good evening and welcome to this meeting of the Health and Wellbeing Board. Item 1 is apologies for absence. Do we have any apologies for absence? Anyone been asked to convey apologies? Yes.
Apologies from Jane McSherry, and I'm here representing her today. I'm Elizabeth Fitzpatrick. I'm Assistant Director for Education and Early Help.
So apologies from Sarah Goad, who's the Chief Executive of Age UK Merton. I'm Jen Goddard, Head of Services, representing her.
You're welcome.
Dr. Karen Worthington.
Let's come on next.
Dr. Karen Worthington on leave at the moment.
Okay, thank you. Any more? Okay, item 2 is declarations of pecuniary interest. Are there any declarations to be made? Okay, item 3 is the minutes of the previous meeting. There are some issues which we have identified already, and in particular, there are some people who were here that were not identified as being present, and there were some of you who were here twice according to the minutes, so that's pretty impressive. So are there any other issues relating to the minutes? No? Okay, well in that case I will sign them and done. So item 4 is understanding health inequalities. And is it Mark or is it Dagmar?
Good evening, Chair, and good evening, members. It's me, so Dagmar Zeuner, Director of Public Health in the London Borough of Merton. I'm delighted to see the new members of the Health and Wellbeing Board, and I'm really welcoming the opportunity that the Health and Wellbeing Board today in particular it wants to revisit its focus on inequalities. So my task is just to give a very potted version to set the scene. We are all, I think it's fair to say, NHS, local authority, all our partners around this table, united in our aspiration and ambition to reduce health inequalities. But in order for us to be really clear what we mean and what we're talking about, I'm just pulled together a few slides so that we are hopefully on the same page. So Clarissa, if you move us on. So this is the sort of potted version I was talking about. And first, as a reminder, hopefully none of you will really need this, what we mean by health inequalities. It's important to say it's unfair and avoidable differences in health, all sorts of measures of health. So that is quite important because there are unavoidable differences. Breast cancer is more common in women than men, that type of stuff. We are talking about the unfair and avoidable ones. And when we want to do something about it, it is obviously important to understand, well, what causes inequalities. And you will recognize the diagram on the right-hand side. I think that still is the best description of health and what causes ill health. So very, very importantly, it is the social determinants. They are looming very large in causing health inequalities, and that's why it's so tricky to shift. But then there are risk factors. They're a bit closer to what we deal with in day-to-day. So it's the well-known culprits of poor diet, lack of physical activity, smoking, alcohol, and very, very importantly, our increasing understanding how important mental and social well-being is. And then there are obviously health and care services as well. And again, particularly important for inequalities is primary and community. So that's just very briefly. Now a little bit of pulling together, well, what does the evidence tell us about ways of reducing health inequalities? That's what we are here to do. And you will probably all have heard about the Marmot policy objectives. So these are really quite high-level objectives around the what. What can we do to reduce health inequalities? And there has been a lot of evidence backing these up. And if you think about it, our health and wellbeing strategy, our local health and care plan, they all try to, in a way, mirror and follow that evidence. Now, knowing the what is still not really telling us the whole story, because what is the hardest is the how. And so what I've done is on the right-hand side in the little blue box, just put together a few of our sort of learning points. And the one is starting is with health and all policies. So that is an approach that lends itself to actually think about health inequalities not as something like a project that a few people do and then it's done, but that is a way of working and needs to be embedded in all we do. It's in our monitoring, it's in our performance, it's in our policy design. And I think there is more learning for us as a health and wellbeing board and increasingly as a place to do. But obviously this health and wellbeing board in its last meeting, very welcome, has approved the approach. So we want to work further on that. Another thing that will not surprise you, and you've all experienced it, is reducing health inequalities isn't done and dusted in a weekend. It is a real long-term commitment. And a lot of the public service it suffers sometimes from quite short-termism, because that's the way the money is, that's the way we get monitored. But really, it's a long-term commitment. The second one I think we all ascribe to is it's working with our patients, our residents, our communities. It's working with our staff, and then increasingly the recognition that it has to be within our planetary resources. That's the sort of more recent understanding that only a healthy planet can sustain healthy people. We talked about the whole system approach. Some of you will remember our work on diabetes, really importantly, that the learning is the more you can bundle energy and work simultaneously in a way on the upstream as well as the lower stream causes together, the more effective it is. So as an example, when we try to tackle diabetes even just a bit more, there was the council particularly supporting the conditions we live in. So in that example, it was advertising of unhealthy food, looking at catering arrangements, looking at our local plan, and Adrian is here in terms of licensing of fast food outlets. All of those work at the upstream determinants that make it so difficult to have healthy and affordable food. And then while our local NHS and our primary care in particular worked really hard to improve the actual care for patients with diabetes, and remember our learning was there, IAPT, so some mental health support for people with diabetes. So that just gives you a bit of an example. Understanding intersectionality, it sounds a bit jargony, but it's basically clustering of adverse risk factors. We need to consider that when we think about interventions. And very importantly as well, considering whether we go for targeted or a universal approach, or what Marmot calls a proportionate universalism, a bit of a mix. Because Classically, the welfare system is very, very targeted, and it can be desperately stigmatizing. So speaking again from where I sit, if you think some of the obesity services, you have to be really, really obese in order to qualify, in order to be eligible. There's a lot of stigma involved. If I speak to some of my young people, and we've got some today with us, free school meals, it can be quite horrible, although it's well intended, but if you stick out. So when we want to reduce inequalities, we have to consider those things. And so hopefully that slide is a little bit of a potted version. I've given you some references as well. The next 3 slides, Clarissa, if you whiz us through, I won't dwell on them in length, but it gives you a bit of data. If you go 2 back, that one. That is basically the most important slide. It shows multiple index of multiple deprivation in Merton, and it shows you the classical, what we call the East-West divide. It's cut in by deciles of deprivation, and it's important to understand that Merton hasn't got the worst decile. We're starting with the second worst, but what is obviously striking is the differential within our own borough. And, I'm a cyclist. I cycle from Wimbledon to Mitcham. It takes me 15 minutes, and it is absolutely, the reality changes in quite a colossal way. And if you look at the right-hand side, it's important to understand the IMD actually incorporates what we've just discussed as the social determinants. It also incorporates some health indicators. So it is no surprise that most health indicators, in a way, correlate with the distribution of the IMD. And we've given you an important one, life expectancy and healthy life expectancy. So that's, in a way, what we want to shift. If you move us on, I think Councillor McCabe wanted also to have a bit more of a South West London look. Again, the IMD is the background colouring, and to show us where our acute hospitals are situated. Obviously, Merton hasn't got one, but Merton people go to George's, St Helier, and so on. If you move us on. And that is the reference particular to prevention. So as we said in the previous slide, risk factors play an important role. And here I've given you total numbers of people in Merton that have risk factors like inactivity, poor diet, alcohol consumption, smoking. And I wanted to give you the numbers to show you the potential scale and opportunities we have if we could shift even some of those numbers. If you move us on, last slide. So Health and Wellbeing Board, what can we do? As I already mentioned, in June, this board has approved a health and all policy approach. We're at the moment investigating a little bit more what other health and wellbeing boards and boroughs are doing around Marmot. Kingston, you might be aware, Kingston Council has just declared that they're a sort of Marmot council. What I'm particularly interested in that exploration is how councils or cities like Coventry are actually tracking. So how can we measure realistically and pragmatically that we're going in the right direction? And then you will remember last time we said we want to embed. That is the more generic ways of working, but we also want to learn by choosing an exemplar, something that we all agree is likely to help with reducing inequality and is preventative. And we landed on promoting physical activity, and we were asked to scope. So we've worked hard, and our Merton Health and Care Together partnership as well was very involved. So Actively Merton at the moment is in what we call our program, and after discussion with a lot of partners and listening to community, we've now widened it to think how we can scale up physical as well as social activity for all people in Merton the way they want it. And again, this complements really well with the ambition of the new administration in London Borough of Merton to become a borough of sport. So what I wanted to just briefly, obviously open for any questions, any comments, and then just in a way double check that the Health and Wellbeing Board is happy to support our joint work on Actively Merton. And then we propose to bring a bit more of a fleshed out program, update to a later board. That's me done, I hope in time.
Thank you, Dagmar. Are there any questions or comments? Brenda.
Thanks, Chair, and thanks, Dagmar. I've listened to all of this, and I've listened to it in the past. Seems almost like a repetition to me. What I really wanted to ask, and I haven't seen, is during COVID, there were lots of problems with pregnant Black women losing their babies and even their lives. And there isn't any mention. And I'm just wondering, isn't that part of inequality as well?
Yes, Councillor Fraser, absolutely. I have not even attempted to give any comprehensive overview of the details of how inequalities manifest themselves in health conditions. And as you very well raised, the issue around maternity outcomes, the issue we have discussed with this board in detail before about the disproportionate impact on our Black and ethnic minority communities here in Merton of COVID. So there are unfortunately a very long list of inequalities. And by no means do I claim that this quick overview can do justice to all, but the in a way sad reality is that they follow the pattern of that IMD map that I've shown you, and so that needs to be one of the most important compasses for this board if we want to actually make an impact, that we scratch and try to shift that. But any specifics, absolutely, this is not the presentation that dismisses any of that.
Mark.
Thanks, Dagmar. I think that having that overview is really, really helpful. I suppose collectively for us all and through the partnership, it's what do we do? It's what are the actions we're putting in place to address some of this? Because I think actually hopefully we will all be judged on what we do in terms of the services that we deliver. And this is in no way a criticism of Dagmar. I think we need to move into an action kind of phase now that we're post-COVID or post-COVID, the pandemic as we knew it. And it's going to be really key that we bring the projects and the outcomes to the Health and Wellbeing Board in the future, but based on actions. I'm really keen that we focus on that.
Couldn't agree more. Dagmar, do you want to respond to that, or?
Yeah. So I think Mark knows that I'm totally with anybody. I don't want to sit and ponder. We want to do now. The good thing in a way is that a lot of what we're already doing does try to reduce inequalities. Yeah. So it's almost inherent in a lot of in what the people around this table do day in, day out, whether I look at our voluntary sector, our health colleagues. I see Sai here, he's running Wideway practice, that's in the east of the borough, and it is an outstanding practice. So all of that is work to reduce inequalities. Yeah, so I think it's clearly not enough, but it is actions. And so as I said, it's the double emphasis to say we need to embed it and we need to question ourselves, whatever we do, have we considered the angle and the particular emphasis on inequalities? And then are there some specific actions that we can do to learn how we can galvanize, the efforts around all partners to make a difference. And I'm quite excited about pushing activity because it has energized people and it is quite a positive frame where you can, in a way, accommodate a lot of the preventative ambition and work with our residents and people. And I'm in a way delighted as well. We've got young people coming a bit later and hearing their voice, hearing their angle, in a way demonstrating that we are working with residents, communities and staff rather than doing to them. So all up for action, and then help trying to think through how we then monitor and capture whether we are on the right track.
Thank you, Dagmar. John.
Thank you, Dagmar, for your presentation, and thank you, Mark, for your focus on the actions. What I was going to say is I think that one of the new administration's priorities around the borough of sport, getting people active, really fits into some of the work of tackling inequality. And it may be worth that we take a bigger paper here, including the work that we're doing and the ambition of a borough of sport.
Thank you. Jennifer.
Yes, thank you, Dagmar. Continuing with the theme of the borough of sport, what concerns me is the inequalities that we face if we go along that path. As we know, sporting activities are costly, and unless these activities are going to be free, I don't quite understand how that is going to help in the long run. So as we've seen with the tennis courts, they ended up being charged and they were not free to access. And I know a lot of the tennis courts are being considered to be improved. And again, I would hope that they would be free. Otherwise, all of these improvements are not going to help inequalities or the health of those in the borough. Thank you.
Is there anyone here that could respond to that? Yes.
Yep. Through the Borough of Sport, sorry, it's Adrian Ash, Interim Director for ENR. Through the Borough of Sport sort of theme, we're accessing a lot more tennis courts, but a whole range of sporting activities are being presented. And we are looking obviously actively at trying to make sure that they are accessible to everyone and not just those that are paying. We are currently just coming back to sort of some of the points that Dagmar made. I mean, although we are a borough of sport, we also need to look at how active we are. It's not just about playing games and participating in football, tennis, or whatever else. It's also about sort of the more, what I would say more, it's probably the antithesis, static sports. You know, I know that in John's area, we have libraries where we carry out sort of yoga and other exercise elements. So it's about accessing all areas and trying to improve activity, not just sport. But from the point of view of the Borough of Sport, we are looking at a whole range of possibles, which would not exclude anyone.
Thank you, Adrian. I mean, I have to say that I was on granddad duties today. It's Tuesday, and I took my 2-year-old to the playground at Figs Marsh, which is an area of deprivation, high minority communities, and I was actually quite impressed to see lots of people on the tennis courts playing tennis. Now, it's possible that they may not have paid and they were making use of the facilities. I don't know quite how that works, but I mean, if they're not in use and people need them, and it's going to get people moving and active and, you know, tackling some of the issues that we all are so familiar with, then, you know, I think there's no point in having tennis courts if they are priced out of the local market. And, you know, what is the point of having them if people can't afford to use them? So I think I agree with the point that you're making, and maybe we can push that along. Also, John, perhaps you can help me here, but social prescribing, we've heard a great deal about that. Is it going to be possible for people to be given a social prescription to go and join or get access to tennis courts and indeed any other sort of sporting activities that will get them moved, get them active?
I think it's, sorry, I think that would be a really good suggestion, but I'll leave that one for my colleague Mark.
Mike, your mic's not on, John.
Sorry, it's on. I think that would be a really good suggestion and something that we should look at. The detail of that, I'll leave with Mark Creelman, if that's okay.
Yeah, I can certainly take that away. I think one of the things that we have discussed before is when we're using social prescribing, have we got the services and have we got the voluntary sector to deliver that? And there was a piece of work that we were going to kick off, just looking to make sure that where a need was identified, that there was actually the service. So I will take that back into social prescribing and follow that through.
Well, having said you were looking for action, not words, then you know, there's an opportunity for you to demonstrate that that's exactly what you're doing. So we'll look forward to hearing the results of those conversations. And I suspect our colleagues from the voluntary sector would be very quick to say, it's all very well saying, are the voluntary sector prepared and ready? But the sector can't do anything without the sort of funding that's required. And at the moment, given the stresses and strains on our community, my sense is that our voluntary sector are doing Herculean work, and, you know, don't expect them to magic resources out of thin air. Do think about how we can support them to make what we're trying to achieve in Merton that much more effective. So I'll say that before you do, shall I? Mark, you're going to respond.
Yeah, I think we accepted that. I think when we talked about it previously with the voluntary sector, it was a case of work with us to ensure that we're putting the resources in the right place. And if that's additional resources, help us identify that. I think the sport question is also us working with our council colleagues around actually what is possible in terms of social prescribing and actually what's the cost, going back to your question about how do we cover the cost of booking a tennis court, etc. So I think there's a piece of work we need to kind of take away with social prescribing in general.
And you'll come back and tell us what's been achieved and how many extra people are.
I certainly will.
Good. That's a challenge accepted. Thank you. Any other questions? Well, I've got one. There was a reference to Thurrock Council's whole systems approach to tobacco control. I'd be really interested to hear more about that. So is that you, Dagmar, or is there somebody else that can?
Yeah, so we can definitely pick that up, because you're absolutely right. If we look at the risk factors, smoking is one that is very patterned by inequalities, and so anything that we can learn in order to spread and help to give up smoking amongst Merton residents, we are delighted to go for it. So I'm taking that wholeheartedly.
Okay, I was kind of hoping you might be able to tell us what they're doing in Thurrock, but perhaps that will require a bit more research.
Yes.
But what was in my mind in raising this was that I'm very conscious that tobacco kills, it causes all sorts of, we all understand the impact in terms of health, and the cost to the health service is huge. But the other thing that was in my mind was the cost to individuals who are addicted to tobacco, particularly people on very low incomes or on benefits. The proportion of their income that is spent feeding that addiction is astronomical, and it means that they go without, and their families often go without. And so anything, I mean, particularly at this time when people are really struggling with the cost of living, anything that we can do to help more people, more money in people's pockets who are really up against it, I think needs to be encouraged. Mark, have you got any specific plans there, or is that something you'd like to come back and tell us about and accept yet another challenge?
And accept that as another challenge. But yes, I mean, I think just in terms of smoking cessation, particularly, what we need to do is, going back to Dagmar's presentation as well, ensure that as a system, all partners are linking up to do whatever they can do to kind of support people in giving up. I'm totally with you in terms of the amount of resources that, smoking is an incredibly expensive habit. Yeah, and yet it's probably the people that can afford it least that actually end up smoking. So I think, again, there's got to be a joined up approach to how we tackle that.
Brenda.
While we're talking about smoking, vapor is on the increase. And I'm just wondering, from what I've been reading, it's not much different from smoking anyway. And I am very concerned that a vapor shop has opened on Manor Road at the traffic light near to Merton College, near to the college. And lots of young people find themselves in there because they're not even selling just vapor. They're selling sweets, lollies and everything. And I understand there's no planning. So we need to be careful to see where we're extending this to. Because smoking, yes, as a nurse, I know what it does to people. But vapor apparently is not a good thing, and especially for our young people.
Is there anyone here that can give us some guidance on the latest information about vaping? I suppose, Dagmar, you would be.
Yeah. So very briefly, I think Councillor Fraser, you've picked up a really important point, that vaping as an alternative to tobacco smoking has less health risks, but the unfettered taking up of vaping by young people is something that is of concern. So we're not the only ones trying to manage and navigate that tangle. And so in London, there is the Tobacco Alliance. They're working on it. There will be a big meeting in October that particularly looks at a concerted sort of approach to vaping and young children, so that it doesn't get tangled up with vaping as a smoking cessation aid for entrenched smokers. So, and we are very engaged in that discussion, and will bring it back and implement it as required in Merton. And I think Adrian, being here as well, it will be very important to include our licensing colleagues in those discussions.
Are you accepting the challenge, Adrian?
As everyone's accepting a challenge, I'm happy to accept that challenge also. Thank you.
Okay, the other thing that I wanted to just ask a question about is that I noticed under health inequalities, what do we mean? There is a bit of a sentence there that says access to services. Now, at the risk of sounding like I'm banging on about something, the reason that I asked for us to identify the location of St Helier Hospital is I believe that the location of a hospital does make a difference. I hear colleagues, actually some very senior colleagues, even in this chamber, telling me that I'm wrong, that it doesn't make any impact at all. And I must say that as somebody who grew up in a deprived community, that for middle class people who don't have the difficulties that are faced by some of our communities, including the community that I represent, very easy to say that where you put a hospital doesn't make a blind bit of difference. But if you haven't got the money to pay the bus fare to get there when it's moved from you, then that does make a huge difference. And, you know, it's one of the things that we can make a decision on. We can, you know, there's all sorts of talk in here about housing. Well, the housing crisis that we are facing in this country is not going to be solved in the next few months or few years. It's a long-standing issue, and there's been a huge underinvestment in that for a long time. Issues of education need to be addressed, and again, but they're not going to happen overnight. But you know, we had a choice. We could still make the choice to leave the hospital that serves my constituents where it is and where it has been since the war, or we could move it to affluent Belmont, where people have 2 cars and have no problems accessing services. But we've made a choice, and I will continue at the risk of banging on to raise that point, because that's precisely what I was elected to do, to represent the people that I serve. And I think Brenda has a similar approach to that, and it's the approach of this administration and indeed this council, who at its last full council meeting passed a resolution making it quite clear that we believe that that's a very poor decision and people need to think again. And I was really grateful to the main opposition for their support, because what that demonstrates is that there is overwhelming support for that position within the borough, and the elected representatives right across the borough recognise the importance of that. So do take that one away, Mark. You possibly already picked up that kind of hint that I've made once or twice, but it's not going away, and it's a very real issue, and it's something that is going to be coming back again and again, because we think a terrible mistake is being made. And you know, if you see the car going over the edge of the cliff, then I think you have an obligation to shout, watch out, beware, and that's precisely what we're doing. Any comments, responses to that? Okay. Thank you. I think what we've agreed is that there is work to be done in this area, and it will occupy a great deal of our time and effort in the coming months and years, but we will come back to it at regular intervals and get updates and progress reports, and I think that should be a priority for us all. So item 5 is combating substance misuse, and that is going to be Dagmar again. Am I right, Dagmar?
Yes, thank you, Chair. If you allow me, Barry is here with us, and I swiftly hand over to him, if that's okay.
Thank you, Dagmar. Thank you, Councillor McCabe. But firstly, really welcome the opportunity to talk to you this evening about substance misuse, in particular preventing and tackling substance misuse in the context of inequalities. So the purpose of this item this evening is to consider our approach and the governance of the setting up of the new Combating Substance Misuse Partnership, to think and consider the ways of working between the Health and Wellbeing Board the Safer, Stronger Executive, and also the Merton Health and Care Together Place-Based Committee. And then secondly, to ask that Health and Wellbeing Board member organisations, as they have always done, support us in the ambition of tackling and preventing substance misuse-related harm by identifying a senior lead officer for us to work with over the coming months. So drug and alcohol misuse affects many people and communities all across Merton, and it can lead to significant harms to our communities and individuals. So poor physical and mental health, unemployment, homelessness, family breakdown, and criminal activity. But we do know that its harms are more pronounced in areas of high deprivation and on those from lower socio-economic groups. So within Merton, our strategic approach has been to prevent and tackle substance misuse, and that is delivered through a combination of good, holistic, so that's person-centered services, which is led by Merton Health and Care Together and the Health and Care Plan, and then creating that physical and social conditions to be able to lead a healthy life, which is clearly led by the Health and Wellbeing Board and the Health and Wellbeing Board strategy. I won't go into the details because you can see them in the report, but we've provided some high-level key messages on substance misuse need in Merton, but to be really clear that we do need to understand more about those inequalities, and that will be part of the wider needs assessment, which I'm going to talk on a little bit later. So the first part of the report is about the national strategy. So From Harm to Hope was published back in December 21, and that has three key objectives: reducing drug supply, reducing drug demand, and then delivering a world-class treatment and recovery services. But clearly, national strategy relies on local delivery and local action. So we have been asked by central government to do three things. The first thing we've been asked to do is to set up a combating substance misuse partnership who's accountable for delivering those three high-level objectives. So if you remember, supply, demand, and treatment. The second thing we'll need to do once we've set up that partnership is to deliver a needs assessment, again, thinking about supply, demand, and treatment, and then a plan for local action, really hearing really strong already this evening from the board members about local action. But we're in a good place in Merton, and our proposal for you this evening is that we build on what we already have. Our proposal is to review and refresh our existing Substance Misuse Partnership Board, who has a strategic framework and an action plan on the things that we've been doing to tackle and prevent substance misuse related harm. Our proposal is joint SROs, and our proposal is Dagmar, as our Director of Public Health, jointly chairs that partnership group alongside Chief Inspector Barry Capper from the Metropolitan Police, because that's going to be really important for us when we start thinking about drug supply actions. And as per the current arrangement that we have in place, colleagues, we would report into the Safer, Stronger Executive, but maintain that dotted line to the Health and Wellbeing Board. And then clearly, it's really important that we consider Merton Health and Care Together as a place-based governance as that is being refined. So if you support the approach to build on what we already have to strengthen those arrangements, we aim to hold that first meeting in October and then set up task and finish groups to develop the needs assessment and the local action plan, building on what we already have. OHID, so the Office of Health Improvement and Disparities, has provided some very modest additional funding, which you'll see in the report, to secure improvements to the treatment system. So if you remember, that's one of the three objectives of the strategy alongside supply and demand. And we're able to use some of that to increase the program management support that we're able to have at this stage. The second part of the report is around services, specifically adult substance misuse services. So our current provider is Westminster Drug Project, and it's a voluntary and community sector provider, and they've got some good outcomes. They're delivering well when compared to other places and other providers, but we need to recommission that service by April 24. So to inform that reprocurement, we're developing, as you would expect us to do, a review of the service model, but we're also going to continue the voice, and we want to deliver an engagement program to really understand service user voice. We want to talk to residents. We want to understand that lived experience across Merton, and that will have a real emphasis on prevention and how to meaningfully work with our communities to increase the reach and effectiveness of our services. So again, going back to that ask, the ask this evening, colleagues, is that the Health and Wellbeing Board member organisations identify a senior lead officer to work with us in public health on the redesign of the service, to contribute fully to the Combating Substance Misuse Partnership, the needs assessment and the local action plan, and any opportunities that you see and you hear about how we can better and continue to work with our local communities in Merton, let us know and we will take that forward on our behalf. So I can probably stop there and hand back to Councillor McCabe.
Thank you, Barry. Are there any questions? Jennifer.
One on page 910, detailing health, drug, alcohol data. I'm just wondering about the data sharing on this. I think residents would be quite interested to know which way that's going and whose data is being shared.
Barry?
So, thank you, Councillor. Really important question. Information governance is absolutely critical, and that data sharing agreement. So that's a piece of work that we're working on at the moment, Councillor, to understand, because if we have to do a needs assessment looking at supply, demand and treatment, we will need access to some partner organisations' data. And that's why it's really important, because this straddles so many different organisations to tackle and prevent substance misuse, that we have that joint SRO. So Chief Inspector Barry Capper would be jointly chairing. So hopefully that will enable us to get through the data sharing agreements so that we can really understand the need within the borough.
I see a furrowed brow there, Jennifer. Did that not answer your question?
Whose data are we talking about, and who is going to be sharing? Who is it going to be shared to and with? And what data are we talking about?
So that will be data that's owned by, it could be from our service provider, it could be from the Metropolitan Police Service, it could be from data sharing from the probation service, because it is such a complex area. But Councillor, this is one of the things that we are working through, and we're not one, every local authority has, or local area, sorry, has a responsibility to set up a substance misuse partnership board. So we're going to be relying and working with our regional and national colleagues on that data sharing of who owns the data, how it can be shared safely and effectively and with meaning. And so that's one of the things that we need to do as a partnership board.
I think the answer is they're working on it and they'll get back to us. Is that fair enough, Barry?
Thank you, Councillor McCabe, spot on.
Thank you. And you will, when you've worked it out, will there be some mechanism of letting this committee know? You talked about a dotted line. Do you want to explain that?
Yes, so the day-to-day leadership would come from that Safer, Stronger Executive Board, but we would more than happy to come back to the Health and Wellbeing Board to give you updates on the action plan, so that we can make sure that we're linking with our health and care colleagues all across the borough and the Health and Wellbeing Board. So more than happy to come back with that action plan that describes what we're going to do to tackle this.
How long will you need before you're able to come back?
I think in the first quarter next year, Councillor McCabe.
Okay. I see John and Mark. I don't know which one of you had your hand up first. Look, they're both being terribly polite. It's
I'll go first.
an example of.
No, not at all. So it was just to say that I really welcome the approach as it's set out. I suppose mine is also just a plea about when we're nominating leads, because our primary care colleagues actually are on the front line, and often substance misuse, it's not just about those that enter into a treatment program that is a structured treatment program. We get lots of presentations in primary care, and also we get lots of presentations in places like A&E delivery, in your A&E departments. So it's just about when we're nominating people, perhaps it's a range of people from health, so that we can really make sure that we're making an impact.
You happy with that, Mark? Sorry, Barry.
Oh, sorry, Councillor McCabe. Yes, absolutely. And again, you'll see in the appendix a number of the different services for adult substance misuse services. Some of those operating in the acute, some of them operate in primary care. And I've already started that conversation with primary care colleagues to help us scope the review of the services and to play an active role in potentially services as we go forward. So absolutely welcome to take that challenge.
John?
Thank you, Barry. I thought it was a really good report. I thought that 2.2 was a really interesting point that was made, that substance misuse affects all areas of Merton. And I'm assuming by that you mean all client groups, all age groups, all social profiles, all groups in Merton. But that those in the most deprived areas, the most impact is felt by them. And I'm assuming some of the work that you'll be doing in the board and as a working group is to drill down that data more and find out what action you can take to alleviate some of the symptoms for the most deprived areas. Is that kind of right?
Yes, John, absolutely. That's going to be a really important part of both that engagement piece of work with our residents and frontline staff, but is also, yes, absolutely to understand and to tackle those inequalities. So yes.
Brenda.
Thank you. Barry, 2.9 on page 9. I'm a little bit lost because you said that the police will be involved. Are they being involved in a preventative position, or is it after somebody's been arrested and convicted, or how is it working, please? I work in the courts and I can't actually fathom what you're telling me.
Okay, thank you, Councillor. Really important question. And so as the Combating Substance Misuse Partnership is going to be accountable for those 3 high-level strategic priorities of supply, reducing demand, and increasing the effectiveness of our treatment services. That's why it's really important that we work closely with the Metropolitan Police, probation, and those other organisations. So as we go forward, we're going to need to make sure that we've got clear actions on preventing and tackling alcohol-related harm, and that includes clearly drug supply and drug demand. So very much preventative approach is what we all want, Councillor.
Please do.
Should the health service not be involved in that then? Because they would know a bit more than the police regarding preventative.
Yes. Sorry, Councillor, I didn't mean to interrupt you. Yes, absolutely. We currently have clinicians and health service colleagues around the table in that Substance Misuse Partnership Board, which will be reviewed and refreshed to turn into a Combating Substance Misuse Partnership. So we'll build on those networks that we already have, but the NHS and health colleagues are around that table already.
Thank you. I just think you're perhaps selling yourself a bit short there, Brenda, when you describe your experience with the courts, because my understanding is you've also had extensive experience with the police as well as the magistrates court, and that's quite some experience to bring to bear in such discussions.
Or fine for anything. I work on the other side as a police officer and magistrate eventually. You can't do them together.
I'm happy that you've clarified that. Didn't doubt it for a second. Okay, we've got 3 recommendations before us. I think everyone's had the opportunity to ask their questions or make their contributions. Can we agree the recommendations? Are there any? Do you have any questions? Okay. Can we agree the recommendations? I see some nodding heads, but nobody's actually saying yes, agreed. Or that would be helpful. Thank you. We now move on to item 6, and that's the children and young people's voices. And my understanding is that Sukhpal is going to introduce this.
Thank you, Councillor, and thank you to the Health and Wellbeing Board for allowing us to visit today and talk to you about participation and youth voice. My name is Sukhpal and I'm the Participation Manager at Merton Council. I'm here with colleagues from Public Health and Young Inspectors. Before we go into the presentation that we've got, I'm just going to allow our Young Inspectors, Anna and Lola, to introduce themselves.
Good evening, everyone. I'm Anna. I do quite a lot of work for public health, such as work on the Under 18 COVID Champions Group, Peer Educator Project, social prescribing, and My Health. So it's lovely to meet you guys. So yeah, I'm going to pass over to Lola.
Hi everyone, I'm Lola and I'm also a young inspector and then also a lead young inspector for BFA, which is the Students Outcome area.
Can I welcome you here and also thank you on behalf of the community for the work that you are doing for the community, which is much appreciated. So over to you and your presentation if you're ready.
Thank you. Could we get the presentation up? Thank you. Yep, next slide, please. So Lola is going to talk to us in a couple of slides about our impact of COVID-19 on young people in Merton. And as she mentioned, she's the lead young inspector for our Children's Trust Board on being healthy. And then Anna will talk to us about our public health participation and how young people's voices are heard. And then we have a set of questions and discussion points for you all. Next slide, please. So our young inspectors have defined participation as the act of allowing children and young people to have an equal and equitable say on matters that relate and are important to them. Our young inspectors are young people who empower the voice of young people in and across Merton. They are connected to Merton in one way or another. For example, we have young inspectors who were part of our youth parliament who sit in this council chamber and have transitioned into a paid role with us. There may be care leavers or young carers or just young people in the community who want to have their voice heard and empower other young inspectors. As a participation team, as a bit of a background, we have 2 full-time participation workers and we have 4 young inspectors who work across our education and public health teams. Next slide, please. So at Merton, our participation is a universal approach. So we listen to young people across the borough. For example, our Children in Care Council is called Our Voice, and you can see the logo there that was designed by one of our young people themselves. And we also, as I mentioned, have a youth parliament that has been going for many years that sit in this council chamber. And recently they commissioned a piece of work to empower other young people to have their voice heard and facilitated a bid and a pitch process that was similar to Dragon's Den, where they invited young bidders to the committee rooms here and asked them to present their ideas, and the executives of the youth parliament chose to go with Mordenhall Park, and will be implementing a fishing club where young people can safely learn the skills to fish and also to be able to get skills and hopefully accredited training in relation to that. We have other opportunities for young people to have their voice heard, such as those within the education system in relation to our Black Lives Matter Equalities Forum, so young people can support us to diversify the curriculum, as well as that implementation of a youth advisory forum for children with special educational needs and disabilities. We recently facilitated workshops with young people and the Met Police, which included a project around reverse mentoring, and we've implemented a rights and entitlements workshop for young care leavers, so they're aware of what is available to them in and outside of Merton. And we also have young people represented from Merton on other boards, such as the London Youth Assembly and Pan-London forums as well. So that was just a bit of a whistle-stop tour on participation. But I'm going to hand over to Lola to talk to us about the impact of COVID-19 on young people, particularly focusing on health.
So about 2 years ago, we did a COVID-19 report, which council wanted to know what impact the COVID has had on our young people and also our young residents. And during the survey, we realized that there has been so many barriers in so many different areas of our young residents, and over a third of our young people said that they were worried about their mental health. And there is during lockdown, and then also as of lockdown. There is many factors that has contributed to this, and some of them are being safety. So only 1 in 10 said that they felt safe or unsafe in melting, with 4 times as many said that they felt safe or very safe. So melting is a safe area which our young people are happy with, but there are some areas within melting that our young people felt unsafe or they're not really sure about. So the areas are College Road, Pollard's Hill, and so those are the areas that they felt unsafe. Sensitive groups were more likely to be very worried like those with care experience, disability, young people, and young carers. We heard in our interviews that focus groups that's feeling worried about safety from COVID-19 was often from young people who were at risk or had family members who are at risk of getting COVID. So they were worried about like COVID or going out to meet their friend because they don't want to like catch the COVID and then take it back to their vulnerable family members. So most young people felt like they could not go out in that period, but in general, they were not scared of COVID because they know someone does have had it, or they know how it felt, that they have had it already and they were not so sick on it, but they were most worried about their family members being sick or catching COVID. So then we had the food poverty. So we found out that many young people living and studying in multi-faith food poverty, skipping meals or not eating for a full day, but there is not enough food. We only add secondary school students because it's not appropriate for primary school students. 1 in 10 young people has had to skip meal because there were not enough food, while 1 in 20 went a whole day without eating. Or with young carer and care experience, young people more affected. I think with the safety and food poverty, this has had a big contribution to their mental health, especially being worried about what they could eat or being worried about them about their family member not feeling safe during COVID period, or they are not feeling safe if they go to some areas. So during COVID-19 and lockdown, had a negative impact on the physical and mental health of the young residents. During the focus group and interview, we were told that they are informal support from their about their mental health as in friends and family, because they were not able to get professional appointment or speak to a professional expert because due to the lockdown, due to the restrictions, and also due to them not able to make an appointment, having to wait 6 months or more to get an appointment just to speak to someone. So they rely on their family and friend, which is good to see that they have those supports in place. But in January, that is not really the type of support that they needed. They needed like a professional support to help them out with their mental health. 1 in 4 told us that they had found it harder or much harder to access service for their mental health, with disability young people and those in care more likely to find it harder. We've got a video clip that explain like a bit more about the survey in details. So I don't know if you have time to watch the video, or if you guys want to maybe look at that later on after the meeting. Thank you.
Thank you so much. So yeah, moving on to the under 18 COVID champions group. So we've done some survey results last year, and as well as all the broader COVID work, we've been able to shape how we work with young people. So the under 18 COVID champions network allowed for feedback to be gathered throughout the pandemic. For example, from in-person sessions, as well as using tools such as Mentimeter. This enabled us to hear the voices of young people of how COVID has affected them. The results showed the overall impact which COVID has had on mental health, social isolation, and loneliness of young people, as well as our myth-busting sessions showed how young people listen to social media information the most, which has quite a lot of misinformation, as you can guys imagine. This highlighted the importance of providing safe spaces for open discussions to allow for accurate information. The survey results and feedback from sessions showed the reliance on family/friends for information and support as the first port of call. Furthermore, the project also highlighted the importance of youth-friendly messaging and engagement, and the importance of considering digital inclusion to ensure all communities have equal access to projects and public health messaging. Lastly, we learned that young people want their voices to be heard, as they feel that they don't always feel that they have a say in the services that affect them. Next slide, please. So this slide here alludes to the various different experiences of young people we've obviously had in the past. As you can see on the top left-hand corner, that picture shows the difference in mental health of young people. As you can see, the experiences are very similar, but they can also be very dissimilar. 1 second, so sorry about that. But yeah, and on the bottom right-hand corner, as you can see that when young people done that word cloud, we saw that, you know, even though they live in different places, a lot of things can bring them together, which is so important when we do sessions with young people. Moving on to the next slide, please. So we have taken these lessons learned forward in our new projects. The two you can see on the screen right there. For example, the Peer Educator project was designed to focus on those who have been most impacted by COVID and pre-existing health inequalities. The Peer Education Network is open to young people aged 16 to 30 within Merton to improve health and well-being, specifically targeting most underrepresented young people, such as those with SEND, care leavers, those not in education, employment or training, those from Black and ethnic backgrounds, and those with experience of the asylum system. These groups were identified from local data, such as the resident survey and national data regarding groups most impacted by COVID and existing health inequalities. The project provides accredited training to peer educators to design and deliver engaging campaigns within their community around aspects of COVID and COVID recovery, which are important to them. We have also taken lessons learned on the importance of listening to young people's voices and acting on it. The network acts as a link between communities and public health for improved advocacy of young people. The project also focuses on sustainability and creating a network to share wider public health messaging, and also enables for other emergent issues such as the cost of living crisis and employability to be addressed through the network. Moving on to the My Health pilot, this project has enabled us to strengthen partnerships with local healthcare providers. Young people from that project will feel greater understanding of the service offered by practice through participation, and as well as the reducing health inequalities by engaging and working towards improving outcomes for marginalized groups. And lastly, young people feel supported to be engaged positively with their own treatment and care. Thank you so much.
Thank you, Anna. Thank you, Lola. Just before we move on to our discussion points, do we have any comments or questions?
I've got one, but Brenda's got one too.
Thank you both very much for what you're doing. You're very brave, and the work is very good. I've just got a couple of questions. One is, how are you ensuring that young people who are not involved in what you're doing, hearing what you're actually doing, because it affects everyone? So what have you planned? What sort of programs for them for the word to be disseminated? And one was Lola's about food poverty. I'm surprised to see that it's still continuing, considered what the footballer did, and things were going well. And it's not for a day, and it's not for a week, it's continuous. And I'm sure we all know that lack of food affects mental state. And young children who are not getting the proper food are unable to learn properly. So what are we doing, or what are you doing to ensure that we hear you and do something about it?
Thank you, Councillor. So I've attended a couple of meetings, presented the Western survey to members of the forum, and they've went away to feedback and say what they can do. We've been in touch with Traceability. They say some members they work with like the food bank, so they've been able to organize some food bag for our young residents who need them, and they can go in there and pick it up. So there is quite a few work that they do at the moment, but they say quite a few more to be done. And I don't know if you want to say anything else, add anything more to it.
We also have a care leavers hub in Mitcham, and with our health and social care colleagues have introduced a pantry for young people. So the participation team there on a Wednesday, and we're looking to implement social workers and PAs, personal advisors, to be there throughout the week. That young people can drop in and pick up some non-perishable food, and that will be restocked by my team on a regular basis. And we're also looking to work with counsellors and also other supermarkets around the Mitcham area to ensure that we've got accessible food that young people actually want, because everyone has their personal preferences, so we need to be catering to our diverse communities. So that's one of the ways to answer your second question. Probably Anna is going to respond to your first one.
Yes, so to respond to your first question, I think the most important thing is building a very strong network of young people together and forming that basis. So for example, with the under 18 champions work I do, we have a group of champions, and their kind of goal in the beginning from the get-go was to disseminate information that obviously we pass public health, key messages, and that is obviously a really strong thing that we obviously told young people to do. Obviously, I do appreciate at the same time, that a young person may forget to pass on information, and that information may be blocked off from another person. And that is when, for example, media source channels come into play. So a lot of the time in the past, what we've done was we created videos for young people, and those videos were disseminated across schools across the borough, if it's primary, secondary schools. So they were hitting quite a lot of young people, and even, for example, the under 18 champions group, we've obviously said in the past, any resource you have, pass it on to your friends, family, parents as well. It really depends, on the young person. But I do think that media is a really big thing for young people, because obviously it reaches quite a lot of, young people if they're 13, 15, 19, for example. But even the projects that we're doing right now, for example, the Peer Educator project, we're obviously targeting the underrepresented groups through, for example, media, going face-to-face, talking with them, and obviously forming that strong network really creates a lot, but yeah, if that answers your question.
We have 7 good libraries in Merton, and I'm just wondering if you're disseminating some of your material, even in leaflet form, in the library.
Yes, I do know that in the past we did disseminate leaflets, or if it was posters in the past, to libraries, even youth centres as well, as I said, schools. It's basically across a lot of things, especially during the high peak of COVID. We had to obviously disseminate to basically every single, young person friendly, place. So if it was library, schools, so yeah, 100%. And we will definitely continue to obviously share it, because it is very important. Because I do appreciate sometimes even digital exclusion comes into play, where obviously a young person may not have a phone, so obviously they might go to a library. So I do appreciate that. Yeah.
Mark.
So firstly, thanks for a great presentation. I suppose my question is a kind of really practical one. When you're talking about health services, are you working, how plugged in are you with the Mental Health Trust? And kind of CAMS commissioners and stuff like that. Is that something that we could strengthen? Is it something we can support you with? Because actually that would be really key in terms of shaping services going forward, wouldn't it?
So in terms of mental health and CAMS, I do know that in the past, during the high peaks of COVID, for example, my one project I was doing, under 18 COVID champions, we were linked in with Off the Record, for example. We were talking with CAMS at the same time as well, just because we wanted to hit all the bases. But I do think moving forward, because mental health is so wide and it hits a lot of spectrums, I think it's important to strengthen anything that is already strengthened, because anything can obviously improve. So yeah, by all means, I would, love all the obviously support, especially for the Peer Educator project. Mental health comes into that as well, especially with My Health pilot as well. So definitely, yeah.
I think our Mental Health Trust South West London and St George's would be really interested in the work that you're doing, and would love to kind of join up with you so we can link that up.
Well, that was actually related to the question that I wanted to ask, and that was, I think Lola mentioned that people were relying on informal networks rather than being able to access the more formal services. And I've heard that in the pandemic, young people that needed help and support were not getting it. I wanted to find out, and I don't know who can, well, I mean, you can probably give me the young person's perspective, whether it's improved. And I don't know, Mark, are you able to comment on what kind of, or perhaps education, are you able to tell me what kind of delays there are now? Because I've heard some, in fact, real horror stories about people young people desperately needing to access help and simply not getting it because it's not there. What's your experience?
So thank you for the question. So from our recent survey, and they're also speaking to our young people and feedback to them about the survey and the feedback, it's an ongoing issue with trying to get access to the mental health department, trying to access professional appointments. It's like they're waiting longer than they needed. And I don't know if there is something that is causing the delay for our young people actually getting those help that they needed. It's like they call the GP and the GP say they're fully booked, or they have no appointment, or they're only open like a short hours, and they have to call back the next day, and they call back the next day, and is it the same repeat issue? So I don't know what we need to put in place to solve those barriers and actually have those changes made. So I don't know if someone is able to help with those questions.
So I think what we probably do need to look at is perhaps it's a future health and well-being kind of topic, is around mental health, because I think actually underneath kind of mental health diagnosis or mental health services, there's such a vast, like you were saying, there's such a vast amount of different presentations. And I do know that previously we had issues with people getting a kind of ADHD diagnosis, or if it was a child with kind of learning difficulties, that could exacerbate kind of waiting times. So I think what we could do is look at the different sections of mental health services, the different waiting times, and bring something to a future health and well-being. I do think probably it's really key that a mental health provider brings that as well, because actually they really can lead the conversation about how they might be developing services. Because I do know, and this was the same with adult services, that during COVID, a lot of kind of virtual access was kind of switched on. Yeah, now virtual suits some people, it doesn't suit everyone, but actually what we have seen is a kind of tsunami of mental health presentations across adult and children's services, really, because which is in one way a good thing, because people are identifying that they've got a mental health issue and want support, but actually we have to then develop the right services to plug them into.
Refer to education, forgive me, I'm still back in the day. I've been here a long time.
Please don't worry, Councillor. I think It is, as always, very, very useful to hear directly from yourselves as young people and what you're hearing our young people saying. And I think the idea of some greater scrutiny and asking CAMs to come and talk would be, it sounds very good. I just wanted to reflect that some of the things that we are trying to do for young people. So every school in the borough has access to a mental health team. Mental health teams in schools, which is significant. National average is something like 25% of schools have access to those teams, so those are there. There is off the record that you mentioned there, Anna, as something that young people can self-refer to, as well as actually relying on professionals to support them to do that. And then we have COOF, which is again a service available to our young people. So that's just some of the things, but we can always do better, and we do need to look at this more. So absolutely should recognise the tsunami of mental health issues that our young people continue to face. And we talk about living in a post-pandemic world. Well, the impact of the pandemic continues there in terms of young people's mental health, quite definitely. In terms of young people's access, I would have to go away and have a look at some of those figures. I don't have those figures for you, Councillor, I'm afraid.
Okay, thank you. And the teams working in schools, are they teams of professional mental health workers, or are they teams who are already in the schools performing another role that have been given some additional training?
These are additional people. These are professionals. These are psychologists, I would want to say. I'm just looking to Mark there. And obviously they then have to link into schools' own systems. So one of the things the government has been trying to do is to get a mental health lead in every school, and they are offering training. So there's a synergy there, but the mental health teams in schools are additional professionals.
That's good to hear. Okay, so are all the questions asked? Sorry, I'm afraid I don't know your name. Forgive me.
Hello, I'm Laura Jarvie. I'm a GP and I'm one of the primary care leads in Merton with the ICB. Thank you for your really useful presentation. I think what I see in the surgery every day is the tsunami that Mark described. We really see it firsthand, and it's disheartening to hear that young people still can't get the access to the help they need. And I think it really is simply a demand and capacity problem, and we need to address not just expanding the capacity, but making sure that the capacity meets the needs of young people, whether that be a digital offer through apps like COOF and STEM4. There are others that we recommend to our patients, but also a really meaningful face-to-face offer, not just through CAMs, but also in primary care, and the use of mental health practitioners and other professionals working across the trusts and GP surgeries, but also recognising that my understanding, I've done a little bit of work with Denise from the Young Inspectors, that not all young people would necessarily want to come to their GP or to access support in schools, and I suppose really having a full understanding of where those gaps are and how we can work together with our knowledge of the different bits of the system that we see and your knowledge and insights from the young people that you work with to find out where that help would be best targeted and what we can best do to meet that tsunami of need.
And I suppose that's also being able to support people at the beginning of the pathway, isn't it? Before kind of it becomes a real, do preventative stuff before it becomes a kind of an acute presentation, which, needs a clinical intervention, whatever. It's about working together to kind of find out what support, and it's really key that we listen, because I met with some young inspectors who said, it was about the counselling room, is, have a plan, and that will bring them back to water the plant, have bin bags and stuff like that. And there's really practical stuff that people like yourselves tell us, and we need to act upon that and change the services accordingly.
So, discussion points.
Thank you. I think the second bullet point has probably been answered. But the first one is, how can this board champion children and young people's voice and engagement further
John's volunteering.
Well, I don't think I'll answer that bit very well, but what I was just thinking as we were going on, and it touches to the point that Mark spoke about prevention. When we spoke earlier on about smoking cessation, I actually started thinking about people that were already smoking, adults. I've got to be honest, I thought about adults. I work in adult social care, but adults, and trying to get them to smoke. But actually, what I think we need to do with a lot of the work we're doing is also bring in younger people as well, because it is about prevention. It's about working with those young people, children and younger people, to stop them actually smoking in the first place. We do know, to your point about vaping, that these companies target young people with jazzy colors and fancy flavors to get them to take up the habit of vaping. So when we think about anything mental health, again, I automatically think about adults. I am in adult social care, so there is a reason for that. But we need to actually think about CAMS, we need to think about children's, and I think that we should start doing that in more of the work that we do, to actually think about the entire pathway in all age groups, not just the focus, which we always often seem to do, on adults.
Okay, thanks. Just to add to what John has just said, I actually believe that it's a long time that I was a young person, but I have grandchildren and whatever. And I do work with young people, and that's my remit anyway. Children's services here, but outside I do that as well. And I think that you can correct me if I'm wrong, that it would be lovely to have sessions, however many times a month you want it, if everybody can join in. That is a free for all discussion. So you can explain how you feel, and then there are people there who can answer and give you examples. And if we have people with case studies, because we can learn a lot from what other people have gone through. So I don't know if you'd like something like that. And I'm willing to help if I can find the time. So you need to tell me, because I have a wide background in health teaching, the police, the council, the college, all over the place. And so I think I might have something to offer if you need.
Get her number.
Yeah, definitely. Thank you.
Sorry.
Hi, hello. Sorry, I'm Julia Groom. I work with Dagmar as part of the public health team. And just wanted to say that the young inspectors have been fantastic in their work with public health during the COVID pandemic. We're really excited that we're currently recruiting some more young inspectors, because what happens is they all go on to get great jobs and do other things. So we're in the process of doing that. So it's really good to hear the offers that people have made today and the discussion points, because we would definitely work with them and pick up these things, particularly the discussion around mental health. Very interested and pleased that both Elizabeth and Mark were keen to take that forward. I think the project that was described in one of the examples, which is Merton Youth Health, it is at the moment at the pilot phase, and that's about taking a kind of youth-focused approach to assessing, reviewing how health services are doing. So maybe we could take that forward when we've got through the pilot phase with some of the other services as well. So yeah, just wanted to say well done, guys, and thank you very much, everyone.
I think the question that you've asked about how we can have more of a voice in here is one that I'm finding I need some advice on in terms of the kind of the governance issues, and I'm looking to officers to say whether that's been checked and run past legal, because I would need to be reassured on that front.
Oh, thank you. So the membership allows for the council and the chair to determine if we want to change that. So it's something that's perfectly possible. It would just require us to go back to our terms of reference and get agreement for it.
Laura, have I got that right this time?
Yes.
Forgive me for last time.
So I was just thinking about the last question about what are the opportunities for CYP having more decision making for health. And as you'll be aware, we're organising some health services now around primary care networks. I wonder, as I'm a clinical director of one of those primary care networks, I work closely with all the networks across Merton, whether there might be an opportunity to connect the young inspectors with the clinical directors of their networks, so they could be really involved in some of that decision making that's happening on a really local footprint.
Looks like Laura's trying to sign you up here. Get her number. Mark.
And I think it's an extension of that, really. It's for us as organizations to kind of represent you back to the other organizations, the mental health trusts, etc., without overwhelming you, because you know, that we want to make sure we're using you as much as we possibly can, but actually making those links, making the links to primary care networks, making the links to the mental health trust, etc. So I think that's something that we could collectively kind of do around the table.
Anyone else want to say anything?
Just a final point. So, Councillor Fraser, earlier you asked about how we go back to young people. My service have recently launched an Instagram page, which is young people friendly, I hope, even though it's run by me secretly and I'm not a young person, which we are looking to promote that within our education and our youth services as well. So we're hopefully targeting young people who wouldn't normally access our services in another platform. And also to Mark mentioned about linking in with CAMS, we are linked in with the participation worker at CAMS at St George's, but also Anna and I a couple of weeks ago visited the Youth Council at St George's, although that falls outside Merton's sort of geography, that young people from Merton obviously access the services there. So we are linked in with them and we're slowly trying to grow that network across our public health, but any support in doing that will be appreciated. Thank you.
Merton have 2 youth centres, and I'm sure that if you ask them, you can go, one is at Phipps Bridge and one is at Pollardson. And so you can contact them, and I'm sure I'll go and speak to them. And I've seen that place grow, because I knew it when it was, every time I hear a siren, I just cover my face, thinking I live nearby, but not in that ward, I must say. And it's not like that anymore. And a lot of those young people have gone on to actually Oxford and Cambridge. Then they've come and talked to the others, because they just felt as if they had nowhere to go, they're lost. And so I'm sure hearing from you, they can see another side, plus their own health, you know, and development. And going out, I see it as a good thing, because I see that as an ambassador. So you've built the road and somebody else is now using it. So I don't see if they leave and somebody else comes in. I'm not saying that we thought it was a bad thing, but it will always change. If it stays the same, it will become stagnant, I think.
Hi, hi, Councillor. I'm Rebecca. I work closely with Anna and the other young inspectors with the public health team. I just wanted to reiterate the amazing work again that you are doing, and we're so grateful to have you and as colleagues. And just to say, I know that we've said the word network quite a lot, and some of the projects are quite focused on that network approach. And we sort of described the information giving to young people through those networks. But just to reiterate that it's really cyclical, that actually they are so important to hear what is happening in the communities. And, you know, those networks were set up, for example, the under-18s COVID community champions, they were set up predominantly in regards to giving COVID guidance and listening, you know, about COVID. But because we have that established network now, actually now we're hearing things sort of related to COVID, but now we're hearing things about cost of living crisis or other concerns that emerge within communities. So the network and establishing those networks and building trust within communities is really, really like invaluable. And so we need to make sure that obviously we're not just giving information, we're hearing things that are coming back from those networks and acting upon them, so then we can keep that circle of trust going. And that's the way that obviously we have sustainable projects within the communities, and to keep them re-engaged. So that's why it'd be really great for young people to be able to keep having opportunities, to keep bringing the voices from communities and sort of strengthen the advocacy side. Thank you.
I think we've had certainly a few offers, which is encouraging. There are some questions that I would like to get answers to before we commit to what we're going to do in relation to this committee, and you would expect that would be the case. But if we can liaise, then maybe we can bring that back here when we've got a clearer indication. In the meantime, all these people that have offered to link up and help and support, then I suggest you seize the opportunities and get cracking. But we do wish you well. We thank you for your work, as I said at the beginning, and for your presentation this evening. And we're grateful to those of you that have been those of our colleagues who've been supporting you as well. I think that's important to say. So thank you as well. I think we're just done on this, so noted. Thank you very much.
I think it's firstly the King's Fund Inequalities review. So I'll introduce it and Gemma will present it. So just acknowledging the Council's position on the Future Hospitals programme, as you mentioned earlier. But at the last Health and Wellbeing Board, we discussed that there was a King's Fund Health Inequalities review commissioned as part of that programme. And
to interrupt, I've got item 7, NHS and Social Care. Is that what you're
Yeah, so I think that splits into 3 parts. I think it splits into health inequalities, then primary care, and then the BCF. Yeah. Yep. So we asked Gemma to look at the King's Fund review. It really does lend itself to how important our local health and care plan is, because it really is about what services we're putting in at the community. But I'll hand over to Gemma, who'll take you through the paper.
Hi, good evening, everybody. My name's Gemma Dawson. I'm Deputy Director of Merton Health and Care Together. Thanks, Mark. If you want to just move on to the next slide. Sorry, it's a lot of writing's a bit small, but I'll talk through it and pull out the key points. So as Mark said, in the South West London Clinical Commissioning Group, after the outcome and decision of the Improving Healthcare Together piece of work, which was, as many in the chamber will know, is the piece of work looking at the future of Epsom St Helier Hospital and the potential relocation of some acute specialist services there. The CCG commissioned an external review looking at health inequalities. The focus of this review was to specifically see if there was any new information or if any of the data around health inequalities had changed significantly since the previous equality impacts assessments had taken place as part of the decision making. So as part of making the decision around the Improving Healthcare Together process, there was a number of health inequality assessments that were undertaken, both internally by NHS organisations and also some externally. Some focused on specific protected characteristics. So there was a focused equality impact assessment looking at the impact from an LGBTQI perspective. And this all culminated in what they call the final integrated impact assessment, which pulled together all of the analysis around the inequalities of the decisions and the various decisions in that process. So the aim of the King's Fund review was to just go back and check whether any new information or new data or if inequalities had changed significantly since those previous impact assessments had been undertaken. The summary here I'll just read out that the King's Fund review concluded is that there was not consistent data indicating that health and healthcare needs had changed significantly since the previous assessments, and therefore there was not a need to reopen the Improving Healthcare Together business case. It also concluded that the general perception amongst the local stakeholders, so the review looked at desktop information as well as carrying out semi-structured interviews and some engagement with stakeholders. It concluded that the Improving Healthcare Together programme itself will not impact on health inequalities in Merton and Sutton, and that alongside delivery of the Improving Healthcare programme, there is an opportunity to work differently on population health and inequalities. So this additional review carried out by the King's Fund was consistent with the previous equality impact assessments that were undertaken as part of that decision process. The review did note that actually there was some rising trends in prevalence around obesity in the population, type 2 diabetes and mental health illnesses. So if we could just switch to the next slide, please. So I just wanted to speak briefly on how we've used the data, because the review did give us a lot of extra updated information, and how we've used and make sure that all of the recommendations and points in there are incorporated into our ongoing action plans to tackle health inequalities, and also into the plans and transformation plans around the Improving Healthcare Together programme. So I've just highlighted 3 key areas that pick up the recommendations and points underlined in the King's Fund review. The key thing that the King's Fund review said was that it was very vital that we picked up all the mitigating actions that were highlighted in all the previous impact assessments. One of the key things that was highlighted there, which Councillor McCabe had raised earlier on around this issue, is around access. So to make sure that any mitigations around the changing location for some services were worked through. And I know that this is being led by Epsom and St Helier Hospital, and that they've established a dedicated task and finish group, or a travel and transport working group, to look at the accessibility of the hospital and to work together with local community members to try and put in mitigating actions. The key area that we've picked up on lots of the recommendations and points from the King's Fund review is around prioritising health inequalities in our local health and care plan. The King's Fund review report that I'm summarising now was published in April 2021, and throughout last summer we undertook quite a detailed revision of our local health and care plan for Merton, and we were able then to incorporate and look at some of the points, the additional data analysis, particularly around health inequalities in these areas, into our plans. And the third area is around also picking up on the opportunities around the new model of care and changing locating services around the developing the Mitcham Health and Wellbeing Hub. Just want to switch to the next slide. I just wanted to talk a little bit about how we've picked up and incorporating a lot of the reviews and actions around in our local health and care plan. So as I mentioned before, tackling health inequalities is one of the top priorities of our local health and care plan for 2022 to 2024. The health and care plan is our plan that incorporates all of the key actions that together we think we can make a significant impact on. So it's really about actions and projects that bring together partners across health and social care, the community and voluntary sector working together. We've identified projects across the lifespan, so start well, live well and age well. And broadly, we're kind of really focused on strengthening prevention and the role of health promotion. So we have projects that For example, our Health on the High Street initiative, looking at bringing together local businesses and the voluntary sector to use some of their settings to bring out healthcare and health information into those settings. So we have a cafe, some local cafes doing just dedicated spaces for people who might to make it more dementia friendly and to provide more social integration and access to health information. We're trying to have a strengths-based approach, so working with our communities to co-produce and develop initiatives and projects rather than coming up with a project and then kind of helicoptering in and trying to do it too. We're trying to work and listen and lead as equal partners. So a specific example that we're doing, incorporating our plan there, is looking at actively Merton, looking at our proposals, trying to build on the success of networking and to bring communities together to listen to what their barriers might be, and then exploring together what the innovative solutions could be to improve access, their experience, and ultimately their outcomes. Trying to be community-led, as I said before, and trying to also take an intersectional approach, trying to not marginalise and group people together, but trying to adopt and promote initiatives that are inclusive and positive. And we're also trying to do a population health management approach to try and use our data and information to help us target our resources. So an example of this in our programme is that we are developing and pulling together our information around mental health so that we can try to collectively look at understanding the gaps in health inequalities for people who are trying to access mental health services. We're also doing targeting our community health-led clinics so that we can try to increase the uptake for people who might be at risk or of early diagnosis of diabetes, and trying to again create access, more prevention work to improve access for people. And then the rest of the presentation just goes into the details of our projects around Start Well, Live Well and Age Well. I'm aware that I came to the last Health and Wellbeing Board, presented them in detail, so I didn't want to duplicate, but I hopefully have given a flavour of in some of the other things around how some of the projects that we have in our plans are picking out the direct recommendations that will come from the King's Fund and indeed some of our JSNAs and health inequality information. So I'll leave it there.
And I think just referring back to the previous conversation, one of those projects is around the Children and Young People's Mental Health Hub, and actually working with young people to actually scope out what that looks like. But also just in terms of throughout the projects, there's a number of projects which it's really important that we identify them in the right areas as well. So actually that East Merton dynamic, we need to take that into account to make sure that there is access where people need to get to. We'll stop there and take questions.
Any questions? Mark, you're going to ask yourself a question.
I'm not going to ask myself a question. I suppose the health and care plan, we do envisage that it will come back to the Health and Wellbeing Board on a regular basis as a kind of progress update as to where we're getting with each of those projects, just so that the Health and Wellbeing Board is kind of assured that we are, this is the Merton Health and Care Partnership. It's not just a health construct, but it is something that we will bring back on a regular basis.
Got a question?
Or a comment. So Jen from AGK Merton, just to say some of the projects that Gemma spoke about, we're absolutely involved with as a voluntary sector organisation. So the community-led health clinics, we are a shameless plug for a health and wellbeing event we are running at our centre, but people are coming to those, and it's on the 14th of October. There's a free Zumba class, lots going on, but we're linked in with those, and with the Health on the High Street project, we're giving our information across, we're sharing and learning together as a partnership. So I would say it is partnership in action.
I was wondering at what stage you'd managed to get that plug in. I was advised that you would at some point, so And in fact, if you hadn't, I would have invited you. So thank you for saving me the trouble. Health in the High Street. I have to say, I hear a lot about it. It sounds like a great slogan, but I don't see much flesh on the bones. Now, I know you were saying you want to co-produce, which is a very, how can I put it, trendy phrase that I hear. But what exactly does it involve? When is it going to happen? Where will it be? What will it deliver? Those are the kind of questions that I'd be keen to hear an answer to.
Oh, there. Yes, so we just started the project just this year in April, and we have a dedicated project manager that's been working, making connections and networks with voluntary organisations and the NHS. We have the first part of the project going live throughout August and September. So we have the cafes. There's talking on top of my head, but I can definitely through Clarissa send you the information, or through John. But we've got about 4 cafes that are running kind of pop-ups across the borough, where they will have welcoming people in a dementia-friendly space to come into the cafe to have information, go forward. So those bits are actually happening. And then we've got plans in the pipeline to bring cancer screening. So it's really about connecting up sort of shopkeepers or spaces in the high street with potential opportunities around healthcare that we can put together. So there's just plans in around making sure that we can try and bring some cancer screening programs that traditionally had been in hospitals or in kind of even in like car parks or places like that into the high street settings, into more local community areas. So those are plans, but we can definitely circulate some of the other stuff forward. I think it's worth saying that it is actually one of the things that we've identified is that there is an enormous, vibrant amount of stuff already happening in the community under the banner, you know, around bringing out healthcare into the community in Merton. So some of the original plans that we wanted to do around health on the high street, actually what we found is, well, that's already happening, or these people are already doing that, or so actually it's been a challenge to try and make sure that we do something that adds value, that's going to be making an impact and doing the right thing. So yeah, but happy to send forward some more information as well.
Forward to it. Brenda.
For your presentation, I'm just wondering about these pop-up cafes, because I hear about them and I only know of one, and I won't tell you what's happened to that one until you tell me where the others are. So where are they located, please?
I mean, I'm afraid I'm on the spot here. I'm not exactly sure the names of the cafe. I think one of them's around here in Morden, Metrodome, but they are existing cafes, so that they're really not about trying to create a new additional space. The ethos is about trying to use and trying to make existing cafes or existing places in the high street that people might go to more accessible. But I can send you the names of them.
Because of my last cabinet position, the Canon was revamped and everything, and there was a cafe there, and I say was, because it disappeared overnight almost. It was being used, and I don't really know what's happened, but there is a cafe built for that purpose, and it was used for about 6 weeks, and I was surprised when I heard that it's gone.
Is that the place we had the sort of unsatisfactory cup of tea recently?
Perhaps, I don't know. I don't know what happened then.
Then in
But
that
anyway,
case, I
it
can
disappeared.
understand why it's no longer there. Mark.
I suppose just in terms of the conversation, there's a couple of things, because I think in terms of the health and care plan, it was additional projects that we could identify that when we came together, we could make a difference. But actually, it's probably worth us having a bit of a directory of everything that's going on across the borough, so that we share that and everyone knows that. Because one of the things that is a challenge is people don't know where to access things. So I think we can put that together with council colleagues, etc. And just going back to the canon, so there were conversations about us being able to deliver some services from there, which we need to follow through. We wouldn't be setting up a cafe necessarily there. I don't know what happened to the cafe previously, but it was an identified site as part of the kind of Wilson, the hub that we are considering, how we have a kind of hub and spoke model of services around that area.
Because I've heard so many discussions about this cafe, and there's a purpose-built place, which we spent a lot of money on. And local residents are wanting apparently a proper place. So I really agree with having this list so that we know what's functioning and what's not functioning. So because this one came, and now just 2 days ago, somebody told me they're no longer there.
We have a commitment to provide information. I think it's unfair to put people on the spot and say, where exactly are these? Give us the postcodes in a meeting such as this. But, you know, that can be circulated fairly quickly afterwards. Just like to come back to the point that you're making about, you know, talking to communities and listening to communities. And at the risk of repeating myself, the community that I represent held a meeting to discuss the plans about the new hospital, and the people that came down from the NHS were told in no uncertain terms what they thought of those plans. And people at that meeting told me that this is a, and I quote, stitch up. It's been decided already before we even start the process of consultation. And as the whole thing rolled out, I think those local people's views were confirmed. And, you know, the idea that you are listening when, you know, St George's recently rolled out their new forward plan, invited people from the community to come along and comment on it. And the first thing they said is, we're not discussing the siting of the new hospital. So you're asking people to tell you what you think, what they think, and at the same time telling them that you're not interested in listening to them. There is a complete contradiction there. And people in the community that I represent will consistently tell you that nobody's been back to them since. It's interesting because they were told very, very clearly what people thought. So are those people being left behind? Are they not listened to? Or, you know, do colleagues from the NHS think that I'm making this up when I'm reporting what my constituents are saying to me? They do not like these proposals, they reject them, and they, you know, they feel very strongly about them. This is a real issue for them.
I'm probably better placed to respond to that than Gemma. So I think in terms of the hospital programme that came to the OSC was that the implementation of the programme sat with Epsom and St Helier and James Blythe and Jacqueline Totterdale. I can absolutely take your comments, Councillor McCabe, and feed them back through. I think there are comments that we've discussed before. So I will take that back into kind of the ICB and make that very clear that that's your position. The other thing that James did commit to.
That's not my personal position. It's Merton Council's position, and I believe that Sutton have made their position more clear more recently, because I've seen correspondence that says that. So the two boroughs most closely involved with that decision are saying the same thing, and nobody's listening.
The other comment just to make was that I think James Blythe also committed to kind of like ongoing engagement with the public once they were clear about what the programme parameters were, because actually part of it was that it was sat with the kind of central government hospital programmes, and they were waiting and having conversations around standardized builds, etc., etc., etc. So I think there will be planned engagement with the public going forward once they've got a clear kind of timeline, a clear funding mechanism, etc.
Sorry, it is on, but is it working? It is on, but the light's not on. I think it would be worthwhile if we take back health on the high street here as a topic to discuss some of the work that we're doing, some of the work that's going on in our 7 libraries, to bring health closer to our residents, and also to ask the board for other ideas of things that we could do that we haven't actually thought of. So I think it would be quite useful, rather than just circulate the information, we take it back here as a topic, if that's okay, Chair.
To do that, John. Very sensible suggestion. Okay, is that 7A dealt with?
Can I just ask,
Jennifer.
the slides, they're not included in the report. Are we able to get a copy of them?
Yes, they'll be.
Were they
coming-
additions or?
They will be coming round with the minutes. They were additions. Yes, they will come round with the minutes.
Thank you.
So I introduce the next one, which is the primary care update. So again, at the Health and Wellbeing Board previously, we talked about primary care. I do see this as the beginning of a conversation around primary care, because as Laura was mentioning that there's a lot going on kind of at the network level, which our presentation doesn't necessarily cover. So I do think this is a kind of almost an introduction to primary care in terms of the way going forward. And I believe Emma's on the line to present. Emma, are you there?
Yes, I am. Thank you, Mark. Yes, so we've just been asked to, so I'm Emma Gilgrass, Assistant Head of Primary Care for Merton and Wandsworth in the ICB. I'm just going to update on a few areas of primary care. Could we move on to the next slide, please? So these are just the areas we're going to cover, a brief touch on the Fuller report, enhanced access in primary care, and then 2 of our practice updates. Thank you. Next slide, please. So some of you may be aware the Fuller report came out recently, and this was the output of a national review of primary care, and it's setting out a new vision which centres around 3 offers around streamlining access to care and advice for people, providing more proactive personalised care, and helping people to stay well for longer. Along with these 3 visions, there were 15 actions in order to deliver these, shared across the ICB and other organisations. If we move on to the next slide, please. So these are the actions specifically around the ICB and primary care. So it talks about delivering a single system for integrated urgent care for same-day care for patients, evolving our primary care networks, our PCNs, into integrated neighbourhood teams, co-designing this, developing primary care forum at system level, and focusing on some of our key issues in primary care at the moment around our workforce, estates, and having a clear development plan going forward, as well as working alongside our partners and communities in how we plan and implement these actions. So for many of these actions, we've been working on these over the last few years in South West London, increasing appointments being delivered, into recruiting new staff into a range of roles. We have a digital work stream, so looking at how we can improve access digitally, and integrated and our multidisciplinary teams. So specifically in Merton, next slide, we now have our new Merton Health and Care Committee and our Merton Primary Care Board, where we'll be working in collaboration with our partners and colleagues to look at how we locally deliver those actions in the report. So we already have a lot of things in place. We have our 6 primary care networks and our GP Federation and our integrated locality team models, along with our clinical leaders that are already in place, and we'll be working closely with them in developing our local plans. So thank you. So just an update. So as I said, in Merton, we have our 22 GP practices, a growing, very diverse population, and our 6 primary care networks. These are geographical across Merton, and all our practices are members of a network. And we also have our 1 GP Federation, Merton Health Limited, who we've been working with for a number of years in delivering services within Merton. One of our key issues we know is around workforce. So I'm just giving you some numbers around our current numbers of GPs and practice nurses. But since we have had our primary care networks, they have been able to benefit from an additional roles reimbursement scheme that enables them to recruit from 15 additional roles into primary care to work across their networks. Currently in Merton, we have 97 full-time equivalent staff from 9 different staff groups. So we have social prescribing link workers and mental health practitioners, as well as clinical pharmacists, care coordinators, paramedics, and health and wellbeing coaches, among others. And it's for each PCN decides which roles they want to recruit to based on the needs of their population. So some of them may have more pharmacists than others. Some might decide that actually they need more mental health practitioners. And we work with them to plan their recruitment over the year. Move on to the next slide. So I know access has come up in a number of the presentations this evening. So in primary care, our GP practices all provide their core hours, which is 8 AM till 6:30 PM, Monday to Friday. And we have an out of hours service that patients can access through 111 outside of those hours. Our practices also benefit from a local scheme, so our Improving Access to Primary Care scheme, where they receive additional funding to provide in and out of hours appointments for their own patients. And again, they decide exactly what they want to deliver based on their population. So that might be Saturday mornings, it might be specific paediatric clinics, for example, in the afternoon. We also have a national specification around 8 till 8 access. So this is making sure that patients can access primary care 8 AM till 8 PM, 7 days a week. So that currently is provided through 2 hubs in Merton, in the Nelson Health Centre and Wideway Medical Centre, delivering services to our patients. In addition to that, we, in the last few years, put in some local funding to fund 4 additional hubs offering services to Merton. So this meant that each of our 6 primary care networks had a hub located in their locality. As well as this, our primary care networks, under their specification, deliver some extended access that's open to patients within their PCN. So the important thing is that all our patients in Merton can access primary care 8 AM till 8 PM, 7 days a week. So this is what we've had in place up until the end of this month. If you could just move on 2 more slides and the next one, thank you. So from the 1st of October, there are some changes to the way our enhanced access is commissioned. So our core hours for our GP practices remains the same, as does our Improving Access to Primary Care service. The main difference is that our primary care networks will be taking on responsibility for a much larger part of the access delivery. So it's a national specification that all our PCNs will be delivering. They will be required to cover between 6:30 PM and 8 PM Monday to Friday, and 9 AM till 5 PM on a Saturday. So that's the minimum hours that they have to deliver. They are allowed to do some provision outside those hours, and each of our PCN had to put together a plan to submit to us for approval around what they were going to be delivering. So the hours they were going to be covering, the staff that they were going to be using, because the specification focuses on using the multidisciplinary team, so not just GPs and nurses, but involving other staff, whether that's mental health practitioners, social prescribers, or any of those other staff they've got involved. So we asked them to say who they were going to involve in delivering their services and how they were going to deliver them. So were they going to be face-to-face or remote appointments? We wanted to make sure that there was a mix of those services. So those plans have all been approved. PCNs also needed to engage with their populations to look at what services they wanted to deliver as appropriate to their needs. And they all did that. They went out and engaged with their populations. So we knew that with the PCN enhanced access, it actually left a slight gap. So it left a gap between 5 PM till 8 PM on a Saturday and all day on a Sunday and bank holiday. So in order to cover those gaps and ensure that there is still that provision 7 days a week, we'll be reviewing the specification of our same day specification to cover those hours. So from the 1st of October, all our patients in Merton will continue to be able to access primary care 8 till 8, 7 days a week, through the same routes as normal. So they'll be able to contact their practice to book appointments, or also through 111. If they've rung them, they'll be able to book into appointments. We're actually going to be delivering more minutes of service than we were previously, but all PCNs will have that same minimum level of coverage. And we will be reviewing the plans as we move forward. So every sort of 3 to 6 months, we'll be doing a review, as the PCNs will be. So, are there appointments being used? Is this the right mix of appointments for their population? Thank you. Could we just go on? If you go on 2 slides. Thank you. So just moving on to some of our practices. So our Collier's Wood surgery currently has 2 sites. It has its main site and then it has a branch site. And the plan is that these will move into a new fit for purpose building, currently on track to be delivered in 2024. And there's been obviously ongoing engagement around that. The branch site, if we just move on to the next slide. Thank you, has actually been sold by its owners. So the practice don't own it, they were renting it. The owners have sold that site, with the sale due to complete at the end of September. Therefore, patients wouldn't be able to access that site. But actually, due to a number of issues with the site, including some infection control compliance issues, the surgery has not been delivering any services from that site since before the pandemic. But obviously there is now this plan to close the branch site has been brought forward. We will be writing to all patients to inform them of the formal closure of the branch site. As I said, it hasn't been delivering services for the last couple of years, but we have also been carrying out an equality impact assessment on that, specifically on the branch site closure, to look to make sure we are minimising any risk to vulnerable patients and supporting them where needed. But as I said, the plan for the new premises is on track for 2024. If we just move on to the next slide, then the other issue I was going to touch on is the Rowan surgery. I'm sure you may have heard about this before. So we currently have a practice, the Rowan surgery, and the contract of that is due to end at the end of October this year. Over the years, there have been a number of providers of this particular surgery, and they continued to struggle with a number of challenges, particularly around the premises and staffing. And we were concerned that if we continue to deliver services from them, there might be impacts on patient safety and the quality of care. So we have been looking at the options for this going forward. We could just move on to the next 2 slides. Thank you. So we've looked at a number of options. So we could look to extend the contract. This isn't an option. The current partners are not, do not want to extend beyond that. They feel that it would impact on delivery at their own practices. We considered procuring a new provider. Again, we decided this was not an option. It's a small list size, which wouldn't be attractive to bidders, and any new provider would have the same issues as the preceding providers. So our recommended option at the moment is dispersing the list, where the practice would close and patients would be supported to re-register at other practices. We have looked into the other practices and there is capacity. So the local practices, there's a number of practices within 1 mile, and then a further number of practices within 2 miles, and they have capacity to take on those patients. And actually those patients, a lot of them, because of the issues with the premises, have been being seen at some of those sites recently anyway to access care. We are currently undertaking some patient engagement around the option. We've had 2 events already. We had one community event that was face-to-face, and we had a drop-in session at the practice where patients could come in and talk on a one-to-one basis. We were due to have our last virtual engagement event last week, but that had to be postponed due to the morning period, and that's taking place tomorrow evening. And where patients will be able to come and talk virtually to our team about any concerns they have about the plans. After that, we will make a final decision. We could just go on, I think, 3 slides. Thank you. So if we do make the decision to disperse the list, obviously we will make sure patients are supported to re-register. They will be receiving letters with information about the closure and how to re-register, with information about local practices. We also, for those particularly vulnerable patients, we will make sure that they are identified and supported, specifically supported to re-register elsewhere. And we've been completing our equality impact and quality impact assessments to make sure that we identify those patients that would be most effective, and that we have plans in place to support them if the dispersal does go ahead. In the longer term, let's move on to the next slide. Thank you. We are still committed to having the new health facility as part of the Rowan Park development, but we know this is still 2 to 3 years away, and so we're working with developers on that, and we will be working with our local stakeholders to design the model for that building and what we need in there to meet the needs of the local population. But unfortunately, because of the premises and the contract, we weren't able to wait to make the decision on the Rowan's surgery. So if we just have the last slide, just around our next step. So as I mentioned, we've been talking to the patients and the public about the proposal and looking at that for feedback, which we're currently reviewing, and that a final decision will be made by our South West London primary care contracting group at the end of September. And that would then give us a month, if the decision is to disperse the list, to support patients to re-register about it and make sure that they're informed and that we pick up those vulnerable patients. In the meantime, the patients are continuing to be seen, mainly at other local sites. And so we're making sure that the patients are still receiving the high quality of care. Thank you. I think that was my last slide.
Sorry, there's probably just 2 things that I'd like to pick up in Emma's presentation. Firstly, around the access. So it's really important that we reiterate that actually there are more minutes of appointments available to Merton patients as of the 1st of October because of the changes and the leadership of our primary care network. So I think that's a really positive. There is going to be more access to appointments. And then just again with the Rowans, is that we have the 3rd event tomorrow evening, and that the decision will be made by the ICB after that. So it was just to be clear about we're mid through that process.
Brenda.
Thanks, Chair. Mark, you know well that I belong over that section, so it's affecting me quite a bit. It's been going on for many, many years. Over 12 years, we've been promised and broken promises. However, we can move on from this. I suppose we will. We'll have to, because you've already planned it anyway. But you said 2 to 3 years, and we've gone 12 years from when that sign said, coming soon. And so I'm just wondering, what assurance are you going to give us that we will have, it's not a surgery anyway, it's going to be a medical practice. What assurance can you give the residents of Long Thornton that they will have some sort of care center within the next 2 to 3 years? And I hope it's not 3 years, because we just keep getting put back all the time. And there is a second question, but I'll let you answer that one first.
So I just think in terms of, we kind of reiterated our commitment. Now, obviously, there can always be blips in the road that we can't envisage, but actually we've got the commitment. We've got the commitment of the local practices, and we've got the commitment of the developers. So it is full steam ahead, and the words of Councillor McCabe in my ears, just get on with it. There is something about us absolutely proving at that commitment as soon as we possibly can, and that 2 to 3 years is a realistic estimate. Well, if we could try to deliver it sooner than that, we certainly will, but obviously there's a number of different partners at play. Going back to the Collier's Wood presentation, so we are cautiously hopeful that actually a shovel goes into the ground in December ahead of schedule for the Colliers Wood, and actually so it's all three developments in East Merton. We are really committed to providing a network of different services. They will be clinical services. I don't want it to be thought of that when we talk about community services, it's a community centre we're developing. It will be clinical services and other services as well, because it will be a GP-led health centre. So there will still be services that are delivered by GPs there as well. That probably doesn't answer your ask for assurance, but it's to reiterate our commitment to the new build.
Mark, do you think that Brenda, as the elected representative for that part of the borough, who has been fighting to get this sorted for all those years, deserves an apology?
So whenever I've presented at the Rowans, I've always started with the acknowledgement that this has been a long, arduous process for people, and it has been to acknowledge the frustration, to acknowledge the hurt over the last kind of 20 years. 2008, I think, is the earliest that has been quoted to me. So, you know, all I can do is acknowledge that many things went wrong over those periods, but actually what we are trying to do is now really get behind the new build and make the three developments something that we can really get excited about across health and social care. And that's Colliers Wood, Rowans, and also the East Merton Hub.
And you mentioned 5,000 patients, but I don't know if you've been doing any work on the movements of those 5,000. I'm one of them who had planned to stay there to my dying day, but I haven't, because I might need a doctor at some point. And so I have registered with Wideway, and I've been encouraging the residents to register now, and quite a few people have done so. So what is the actual number left of that 5,000? Do you have any idea?
So I think probably I've got Si next to me who has Wideway practice. We are seeing quite a lot of people re-register with Wideway, but also with the Lambeth practice as well. So we are seeing people kind of already re-register. So I think that 5,000 is probably less than that significantly at the moment. So I don't know if you want to come in.
And just to add, we do monitor the list size at the Rowans on a weekly basis, so it is gradually falling. At the moment, the list size is approximately 4,800 patients, so it's falling week by week, and we are tracking where patients are registering as well. And some are going to Lambeth and some are sort of registering within Merton as well, but it's roughly 50-50 between the two boroughs at the moment.
When this surgery was planned, there was facilities were taken. So there was still money to give us a community center stroke and scout out. And I keep asking what's happened to that money and what's going to happen to that shell and core that's there, because we still haven't had any answers as if we're getting any facilities. And if we're not getting the facilities, where is the money? That I was actually in the meeting in this room many years ago when it was offered, and we don't know where it is.
So my understanding is that still money is still available. I think that's from the council as opposed to health. And Councillor Fraser, we will work with you in the identification of that money and just make sure that that we follow through on that. So when we talked about this previously, I wasn't actually aware of that funding pot. We have since confirmed with council colleagues that it is still available, and so we would work that through sooner rather than later, rather than waiting for the new build. And you have my commitment on that.
To add something, the building of a surgery was part of the community as well. So it was the same builders who were supposed to do it. Is it going to be the same? Is it going to be added to it? Or how is it going to work? I need to take this back to meetings, and that's why I'm asking.
So the NHS doesn't own that property, it's owned by Assura. And what we committed to in the public meetings is that we would ask Assura what the plans were around that and work with local councillors, etc., in having a conversation with Assura about what the future of that site would look like.
More, Brenda. Okay. Can I come back to the sort of presentation at the beginning of this, which is about sort of how people can access GP services in the borough. I mean, it sounds wonderful, but the most common thing I hear over and over again is that people can't get access, that they phone up and they're told that all the appointments for today are gone and we can give you one in 3 weeks, by which time you're either recovered from whatever it is that's worrying you, or, you know, maybe it's taking you off altogether. And but that, you know, this sort of vision doesn't seem to be the reality. I mean, the dogs in the streets in Merton can tell you just how difficult it is for ordinary people to get to see a GP. And I'm conscious that we've got some GPs with us, and that this isn't directed at a criticism of you. It's the reality that people in this borough face. And yet it sounds like you've kind of, you know, everything's fine.
No, so we certainly didn't, we don't mean to present that everything's fine, because actually the increased appointments is in response to actually us hearing that there are access issues for people. And I'm not negating that people's personal experience. What I would say on a positive is that actually Southwest London and Merton, in terms of the GP survey, scored 4th highest in the country around access. So there was a lot of people who did say, actually, I can get hold of my GP. That said, we continue to work on a daily basis where we have access issues or long waiting times, and we work with the practices around that. And actually, it is an ongoing battle, because again, going back to the mental health tsunami, I think primary care are also seeing demand outstrip capacity. And in addition to that, we've got the workforce challenges as well, because actually it's very hard to recruit into primary care at the moment. But we continue to try to improve it as much as we possibly can. And where there are individual issues, we ask people to raise those individual issues, and we will work with the local practices around that. But I certainly don't, I certainly don't intend to underestimate people's experience. I know how frustrating it can be. I'm not a Merton resident, but I have the same challenges in my local borough as well in terms of getting access. Sometimes we need to work with our practices around what the solution will be.
If I might just add, I mean, I think Mark has covered the key points, but what I would say is that access to general practice is not just a challenge for general practice, it's actually a challenge for the entire systems. When you look at the root causes of why people need to access healthcare, it's not just health-related issues that are at that root cause. So some of the issues that we discussed today, our local health and care plan, are also key to how we optimize access to health services as well. Fully acknowledge that there is a demand and capacity gap to health services, including general practice, and in part that has been compounded by the pandemic. And there are lots of studies that show that catching up on long-term condition management and complex care for patients and local residents is approximately 2 years away. So there is a significant backlog of care, not just affecting general practice, but also the wider health system as well, which I'm sure you're all aware of. I think the issue about accessing a GP specifically, again, we know that there are falling GP numbers, and as Mark has already said, there is an above average number of GPs per head of population in Merton. So we have, for example, in East Merton, 1 GP per 1,300 head of population, and the national average is 1 GP per 2,200 head of population. So actually, we have got an above average number of GPs, but nonetheless, probably not enough GP appointments that people would like to see. And that's because general practice itself is also changing and evolving, where we're moving more towards a team-based model of care, where you've got a GP overseeing a multidisciplinary team within their practice. And that's what primary care networks is all about, where practices are working together And they're recruiting healthcare professionals that aren't just GPs. So that GP will be supervising paramedics, clinical pharmacists, physician associates. But what's important is not so much whether you see a GP, but whether people actually receive continuity of care. And when you break down continuity of care, there are three aspects that underpin that. The first is that relational continuity with the team, and the knowledge of that team is overseen by a dedicated GP. The second is very much around informational continuity, ensuring that the professionals that are providing care and people who access care have access to the right information and have access to their records. And that is an ongoing piece of work across South West London and in Merton. And the third is how we coordinate their care. And again, that is about how we work together as a system. It's not just general practice. It's about ensuring that people know when the hospital appointment is, ensuring that healthcare providers know what other healthcare providers are doing. So coordination of care is also key as well. So there are several facets to continuity of care, which is why I say it's not just a challenge for general practice, it's a challenge for us as a system. And it needs a whole systems approach.
Thank you, Laura.
I think Si said most of what I was going to say, but all I was going to add was just about the understanding of what general practice looks like these days, and that it is that multidisciplinary team. And from the slides I showed, there's 97 new whole-time equivalent staff that aren't GPs, but they're working GP practices as part of the GP team, and in some cases delivering really specialised care, like clinical pharmacists who are real experts in looking at people's medicines and can provide that continuity both of problem and of professional for patients over time. So I think we can all work together to help our residents understand how general practice is evolving and what the new opportunities might be, as well as, I mean, I'm a Merton resident. It's the thing I hear most commonly if I say that I'm a GP is that people really do struggle to get appointments, and recognise that.
It must be awful for you to just go down the shops. Oh yes, there's that too. Particularly if the kids are delayed getting out, you can't rush off. Okay. I mean, I think the other thing coming back to Brenda's point is there shouldn't be surprises like we got with Rowan's. That was predictable. It could have been much better handled. The fact that the council has agreed to put money in and nothing happened for so long is unacceptable. And if we're going to be working in partnership, we need to have better communication and thought about how the local elected member has to deal with the kind of fallout from situations such as that. So, okay, I think we've given this a good going over. Does anyone have any other questions? No. So the only other thing that remains is the item C, the Better Care Fund, and that's Annette.
Hi, thank you. Yes.
Sorry to keep you for so long.
Oh no, that's quite all right. It's been some really interesting discussions today, so thank you. So for those who don't know me, my name's Annette Bunker. I'm Assistant Head of Transformation for Integrated Care at the South West London ICB, but Merton Place. I'm conscious everyone's been here a long time, so I'll try and be brief. There are a number of papers that we need to submit as part of the Better Care Fund plan to NHS England. So I think for the purposes of today, I'll focus on two of those. One was a request from the committee at the last meeting around what the Better Care Fund is doing to support tackling health inequalities. And then I'll just briefly go through the presentation as well, if that's all right. So is that okay? Just to put up the health inequalities paper first. Sorry, I'm cutting in and out. Oh, okay. So shall I just talk? Okay. So if you're happy for me to just talk through the health inequalities paper. So the Better Care Fund's one of the government's national vehicles for driving health and care, social care integration. And they've recently updated their key policy objectives, and that's about enabling people to stay well, safe and independent for longer, and then getting care at the right place, the right time. So in addition to the broad pieces of work that we're doing around the Better Care Fund, we're also looking at work around population health management to support health inequalities. The key areas that we have undertaken in the Better Care Fund, part of those are around looking at proactive and preventative services, which I think we've talked about in previous meetings, the integrated locality teams that we've got across Merton. They're multi-agency, multidisciplinary teams that work proactively with patients who are at the highest risk. And the Better Care Fund funds a number of the agencies that are involved in that. Because that looks at individualised support, it very much looks at tackling those people that are most needy, and looks at bespoke support for them, which would range from community services, the health liaison social workers that are in place, Age UK Living Well coordinators, as well as the Better Care funding, the community response hub that was started during the pandemic. In addition to that proactive work, we've also got the work that supports people out of hospital, including reablement, 24-hour care where that's required, and increasing capacity in a number of areas to support people post-discharge, but also to help prevent admissions in the first place. As part of that, we fund intermediate care provision, increased capacity over 7 days, and look at, where possible, supporting patients in their own home, and trying to get them out of hospital as soon as possible to avoid deconditioning. In the paper, there's specific areas of note, as well as the community response hub that I've mentioned, the Living Well service that's run by Age UK that supports patients in their own home. And there are a range of voluntary sector services that are supported to look at physical, mental health well-being, including enhanced lunch club offers, improving heating and insulation, and in supporting access to benefits. We've also already talked about earlier on in the meeting about social prescribing. So some of that is funded through the Better Care Fund. And there are other initiatives that support people with dementia, and in terms of end-of-life care services as well. So further activities that we're doing this year, we're working with Merton Health and Care Together around looking at how we can use population health management, particularly looking at frailty and looking at the information available there so that we can perhaps target our resources better in future years. That will be potentially at Merton Place level, and also I understand there's some further work going on within the PCNs to look at their individual populations and what more we can do to support those. So if I pause for a moment there, I'm conscious of time, so I've gone through that quite quickly. And then I'll go on to the Better Care Fund in general, if that's all right.
Please do. Are there any questions at this stage? Okay. Please continue.
Okay, so I'll go on to the actual slides themselves now, if that's all right. So as you'll see from the slide, that this has already been presented at both the officers management team meetings at the council and in the ICB, as well as the Merton Health and Care Together Committee. So I think at the last meeting, we talked really about the Better Care Fund, so I won't go into any further detail on that, but it's really around health and social care integration. Sorry, if we can probably move through the slides quite quickly, if that's all right, Clarissa, thank you. So this is just a brief summary of the funding that goes into the Better Care Fund. 15 million roundabouts comes from the NHS, and others come directly to the council to support initiatives. Then the next slide just gives you a brief summary really of the national conditions, which I've already mentioned some of those, and to reassure the committee that in terms of the national conditions that have to be met, all our plans meet those national conditions. There are also some metrics that we need to include around within our plans. And those are really around, again, keeping people well at home if possible, trying to avoid admissions, but also looking at how many people we can actually get back to their usual place of residence and avoid long-term residential care where possible. So our plans around those include various initiatives that I've talked about previously. And again, the next slide gives you a brief overview of the services that I mentioned previously around integrated locality teams, intermediate care, the rapid response, which is really around getting people support to avoid hospital admission. So that was a whistle-stop tour, but I think in essence, really, the asks for the committee are to note the inequalities work that's going on already, to note that we're actually planning more work alongside the Merton Health and Care Together plans, and then to endorse the overall plan for submission to NHS England later this month.
Thank you. John, do you want to add anything?
Nothing other than the Better Care Fund's key to the work that we do. It isn't guaranteed. There is national talk about us not having it in the future, and it's fundamental to our budget. I mean, many of the things that we undertake, we wouldn't manage without the funding from the Better Care Fund.
Well, Mark.
I think it's also just to build on what John was saying around, it really is, it's one of the mechanisms for us to integrate more together. The Better Care Fund, I think I probably can be a frustrating fund, because actually it's often you are filling in the forms after they've given you the money and you've got to prioritize. And what we actually want to get to a place for Merton is where we're proactively spending this money together. Yeah, because it is a considerable pot. It's £21 million. And actually it covers really important stuff around intermediate care, rapid response, really keeping people at home where we know they have the best outcomes with the right clinical support and the clinical and social support. So I wouldn't underestimate the importance of the BCF, but we want to probably get to a partnership place where we're doing some more proactive stuff with it. And I think that could be quite an exciting place to be.
Just can I add something to that? Just, yeah, I reiterate that completely. And I think this year we got the guidance for the completion of the plans very late on. So it's mid-year before we can do anything. Whereas our aspiration for future years is to be more proactive with the Merton Health and Care Partnership in order to do that work more jointly and proactively. So we're looking at future plans for the next couple of years.
Okay, thank you for that. There are on page 15 two recommendations. Are they agreed? Good. Okay. So I think that concludes our business for this evening, except to say that Simon is attending his final meeting. I don't know how many of these you have managed to sit through, Simon, over the the period. Oh, he's not here. Oh, right, Brian. Sorry, I'm mixing you up. So Simon is he retiring, or what's who can?
Brian, do you want to take that one, or shall I? So Simon is moving on. He has a new job. They are currently, just in terms of Merton Connected, looking at interim arrangements. And I think they will announce that in due course. So it's just, I think we just wanted to wish Simon well on his way. He's done a fantastic job for us. He's really galvanized the voluntary sector and really made a big difference to statutory services as well. It's been a very easy partner to work with. So it's just to thank him on behalf of the committee, really, and wish him well on his way. And there will be a replacement in due course.
Good. Thank you for that. Is there anything else that we need to cover? Okay. In which case, I'll thank you, all of you, those of you that have presented, those of you that asked questions, those of you that have answered the questions, thank you very much for your attendance this evening. I'll declare the meeting closed.